Thank you very much. It's a privilege for me to be here. I'm just getting over a cold, so I think I'm losing my voice a little bit. That's why I'm talking funny, but I think a lot of water will get our way through this, and a little bit of patience. So this is what we're going to talk about the rest of this afternoon. First, since this is a cancer type that not everyone is familiar with, I'm going to talk a little bit about what endometrial cancer is, and then hereditary endometrial cancer and why it's important. And then something that we really haven't touched on today is describe in some detail some of the pathology laboratory assays that help to evaluate for hereditary endometrial and colorectal cancer for that matter. And really what my goal is here today is that I think for many physicians and many clinical scientists, pathology really represents a black box where you submit a blood sample, you submit a tissue sample, a week later, 2 weeks later, a result comes out, but you don't know exactly what goes on within this black box. So that's really for the purpose of the next hour and 15 minutes or so, is we're going to describe in detail what pathologists do, and especially in relationship to these hereditary cancer syndromes. So Marcia and I are having a competition to see who has the grossest pictures.
You're waiting with that one.
I have another one later on too. So, but you have to wait for it. These things are always very exciting first thing in the morning before anyone's had breakfast or like right after lunch. So this is a uterus that's been basically bivalved in half. Here's the cervix here, ectocervix, endocervix. This is the muscle wall. This is the fallopian tube. This is a small ovary, so this is a postmenopausal woman. And this is a very large endometrial cancer or uterine cancer arising from the endometrial cavity of the uterus. So endometrial cancer is cancer of the epithelial lining of the uterus. And we'll see what this looks like microscopically in a second. It's the most common malignancy of the female genital tract in the United States, and especially in the Western world. It's more common than ovarian cancer or cervical cancer. In 2012, there's probably a little over 40,000 new cases and 7,000 deaths. And what's very important is that in contrast to many other cancer types, the incidence of endometrial cancer is actually rising. So there's a variety of very unique features of endometrial cancer that make studying it a little bit different than studying other cancer types. And I just wanted to summarize those here before we talk about the hereditary features. One, endometrial cancer is a very heterogeneous disease. At the microscopic level, it can be divided broadly into two types, endometrioid and non-endometrioid tumors. So these are the different microscopic types of endometrial cancer that pathologists can recognize under the light microscope. Endometrioid tumors comprise about 75%, and non-endometrioid tumors about 25%. Endometrioid tumors are graded grade 1, which is well differentiated, grade 2, which is moderately differentiated, and grade 3, which is poorly differentiated. The endometrioid tumors, especially the grade 1 and grade 2, usually have a better prognosis. They're usually discovered at an earlier stage. They're confined to the uterus, and surgery alone is usually curative for these patients. On the other hand, the non-endometrioid tumors, which comprise about 25% of endometrial cancers, are composed of serous carcinomas, carcinosarcomas, and clear cell carcinomas. These tumors tend to arise in older patients. They tend to, when they're diagnosed, they tend to have tumor outside the uterus that may have spread to lymph nodes or even beyond, and they have a much worse prognosis. So patients diagnosed with either grade 3 endometrioid or non-endometrioid tumors, these tumors are much more aggressive than the low-grade endometrioid type endometrial cancer. So when discussing endometrial cancer, it's very important to know what's the endometrioid or non-endometrioid and what grade of endometrioid. A second unique feature about endometrial cancer is that hormones, especially estrogen, play a role in the development of this tumor type. And you can see this at the level of normal endometrium. So forget about endometrial cancers for a second. If you take a microscopic section of normal endometrium from a younger premenopausal woman in proliferative phase, you'll see that the endometrial glands are test tube shaped and they have mitotic figures within the epithelial cells. The epithelial cells are undergoing proliferation. On the other hand, if you take a microscopic section of normal endometrium in secretory phase, which is associated with lower levels of estrogen and higher levels of circulating progesterone, the glands look very different. They're corkscrew shaped. And they have very irregular shaped, and they have secretions within the lumen, and you start seeing these cytoplasmic vacuoles. In postmenopausal women or women 55 or older that have very low levels of circulating estrogen, the endometrium becomes inactive, so you have cystically dilated glands lined by inactive uterine epithelial cells. So we could talk for an entire week about the role of estrogen in endometrial cancer or breast cancer for that matter. Suffice it to say here is that from epidemiological studies in the late 60s and early 70s, it was shown that estrogens play a role in endometrial cancer development, especially the low grade, the endometrioid grade 1 or grade 2 type endometrial cancers. The reason this was found is that oral contraceptives and hormonal replacement therapy, that when they were first developed, had very, very high levels of estrogen and no progesterone. So when these were given to women, they were very effective in in causing birth control and relieving the symptoms of menopause. But they had the bad side effect that they also induced endometrial cancer. So subsequently, over the years, the estrogen level has been decreased dramatically, and they've added progesterone to these preparations. So now there is no increased risk of endometrial cancer from these modern drugs. TCGA stands for the Cancer Genome Atlas. If you Google this or search for it on the internet, you can read a little bit more about this. This has been a comprehensive effort by the National Cancer Institute to characterize the genetic changes of many different cancer types. It started with ovarian cancer and brain cancer, and more recently colon cancer has had publication, and endometrial cancer, it's not published yet, but the paper's been submitted to the journal Nature for review. But when you do comprehensive gene expression analysis, so this is microarray looking at expression of genes, you can divide these endometrial cancers into 3 groups. Here's one group here, here's a second group here, and here's a third group there. You can see a little bit better when the lights are out. One group here, these are all serous tumors, the non-endometrioid tumors, and many of the grade 3 tumors are here, and they have this classical gene expression profile. This second group of endometrioid tumors has higher levels of estrogen receptor and progesterone receptor, classically what we think of as the endometrioid type endometrial cancers. What was very interesting and unique about this TCGA data set is that there was a second group of endometrioid tumors, again composed of grade 1 and grade 2 endometrioid tumors, that had much lower levels of estrogen receptor and progesterone receptor, and they expressed genes that were more classically associated with inflammation and the immune response. So it just shows that these endometrioid tumors are a very heterogeneous group, much more heterogeneous than we've classically appreciated. A third unique feature of endometrial cancer is that there's a large number of at-risk patients. So it's not a topic of discussion for this week, but a big risk factor for endometrial cancer is obesity and insulin resistance, or type 2 diabetes. This is a good example of not so much genetics, but maybe more the environment playing a role in cancer risk. A second big risk factor for endometrial cancer is tamoxifen. You heard Dr. Liu mention tamoxifen for the treatment of ER-positive breast cancer earlier. Tamoxifen is an estrogen receptor antagonist in the breast. Unfortunately, it has a weird side effect that it acts as an estrogen receptor agonist in the uterus. So whereas it's inhibiting breast cancer development, or it's a good treatment for breast cancer, in a small percentage of women it can actually induce endometrial cancer. And then third, what we're going to concentrate on for the rest of the talk are hereditary causes of endometrial cancer. The main one here is Lynch syndrome, or hereditary non-polyposis colorectal cancer. You'll hear me use either name for this. Cowden syndrome, at least in theory, can cause increased risk of endometrial cancer. Reality is we don't see very many Cowden syndrome patients. Maybe we're not looking for them hard enough, but this is due to an inherited defect, a mutation in PTEN. And then there's other less common syndromes. By far, Lynch syndrome is the most important and most common hereditary cancer syndrome that results in endometrial cancer, and that's why we're going to focus on it. So in the previous talk, we've gotten some good introduction to Lynch syndrome, so I'm not going to go over all this again, but just to hit a couple of highlights. One, it's not due to just one gene. There's a family of these mismatch repair genes that can be mutated in Lynch syndrome. So either MLH1, MSH2, MSH6, or PMS2, and there may even be some others, because this is a pretty large family of genes that regulate DNA mismatch repair. Very, very important, there's no hotspot, no hotspot mutations. So you may have heard of mutations in the genes KRAS or BRAF, or sometimes like EGFR. There's very characteristic what we call hotspot mutations. So in those genes, you don't have to sequence the entire gene. You only go after very specific codons. It makes these assays very, very easy to run, and even very small hospital laboratories can assay for KRAS mutations. Unfortunately, for these mismatch repair genes, the genes are very, very large, and there are no hotspot mutations. That makes the assays much more difficult. I always show this to graduate students and medical students because I think it's a very important concept. Today, a lot of what you hear is that the most important research is translational research, or research on human disease. And since all of us work with patients, I kind of feel the same way. But it's very, very important to realize that these genes that regulate DNA mismatch repair were not discovered in humans first. They were discovered in the 1970s in a very common bacteria that's studied in the laboratory, E. coli, back in the 1970s. And if you go back and look at the original publication, this was in a very low impact journal. It was in some bacteriology journal that really only microbiology nerds were reading. I mean, no medicine person was ever even reading this, so it really didn't make a splash. Later in the 1970s, early 1980s, these same genes were discovered in yeast. And then finally in the early 90s, someone kind of put this together and said, we have these familial colon cancer syndromes. We don't know how to explain this. Maybe these are due to these problems in DNA mismatch repair. When they assayed for these, they found it. So I think this is a very good example of where a very, very basic science discovery in bacteria and yeast led to very important clinical genetic discoveries in humans, but it came much later, 20 years later. So to me, there's no such thing as a trivial basic science discovery. If we don't understand the basics of the science discovery today, it means that we just haven't figured out what its application is yet. So what are the strategies to identify individuals with Lynch syndrome? Unfortunately, these patients don't come into your office and say, hey, I have Lynch syndrome, I need screening, I need surveillance. I mean, you wouldn't be hearing these lectures today if that was the case. As we saw in the previous lecture, sometimes these patients with hereditary syndromes have very, very subtle findings like the little freckles on their lips or discolorations on their gums, and that's something that's probably been overlooked for 20, 30 years in that individual. So one strategy, and some places do this, is they just do genetic testing or sequencing of these genes of all young colon and endometrial cancer patients. But as we've discussed, that's not really a cost-effective approach. If you do that, you're going to bankrupt the healthcare system pretty quickly. These genetic tests are very expensive because the sequencing technology is expensive. These genes are very big. They don't have hotspot mutations. A second strategy that we've heard background on several times today is to employ these at-risk prediction paradigms that based on young age and family history of colon or endometrial cancers. And if the patient fits in one of those paradigms, then perform genetic testing. And this might be Amsterdam criteria. You've heard us say revised Bethesda criteria. There's a new one that we'll talk about a little bit later called SGO criteria. It's specifically for endometrial cancers. What I really want to focus on here is a third approach, and that's to use tissue biomarkers as a first initial screen and then do genetic testing or sequencing of the mismatch repair genes for informative cases. And the whole reason that we can even do this third approach is that right now in pathology we have really, really good tools for assessing these. We have excellent antibodies for the 4 different mismatch repair gene proteins. In contrast, for BRCA 1 and 2, we don't have good antibodies for clinical testing, and that really hampers our ability to evaluate these cancers at a clinical level. So, talked about these. One thing I wanted to emphasize here, you've seen a variation of this cartoon on the mechanism of how DNA mismatch repair works. These proteins tend to work in pairs, so MSH2 will pair up with MSH6 to recognize incorrect matches in DNA when it's replicating, and MLH1 will pair with PMS2. This defect in Lynch syndrome is called microsatellite instability. Now, what also makes this a little bit difficult, but we're all smart here, right? So we'll be able to figure it out, is that microsatellite instability can also be found in sporadic cancers, so non-hereditary cancers. So about 15 to 20% of sporadic colon and endometrial cancers also have microsatellite instability, but it's not due to mutation of one of these genes. Instead, it's due to an epigenetic modification called methylation, and it's almost always due to methylation of the MLH1 gene. So when you add a methyl group to a promoter of a gene, in general, that will inhibit transcription of that gene. So you get less message RNA, and you'll get no protein being transcribed from that message. So methylation of a gene equals no protein.
So is it a gene knockout or knockdown? You still have some production?
You'll still have the gene. It's pretty much effectively in the tissues that have the methylation, there's no protein. Occasionally you'll get some where there's less protein. And what that threshold is, that less protein equals microsatellite instability, no one knows that yet. So what are the tools that we have in our clinical tool belt to evaluate for Lynch syndrome? One, we have very good antibodies that we can perform immunohistochemistry for these different mismatch repair proteins. We have very good PCR primers for 7 different microsatellites that we can analyze microsatellite instability using polymerase chain reaction, or PCR. We also have a very good PCR-based MLH1 methylation test. So if our immunohistochemistry shows loss of MLH1, and we don't know if it's due to mutation or methylation, we can analyze for presence or absence of MLH1 methylation. BRAF mutation is a very easy point mutation, hotspot mutation. We'll talk about its utility in Lynch syndrome testing as well. What's very, very important is that all of these can be performed on formalin-fixed, paraffin-embedded tissues. And I'll show you what that means in the next slide or so. These tests don't require any kind of special, they don't require frozen tissue, they don't require acquiring fresh tissue. This is another very, very important feature because these formalin-fixed, paraffin-embedded tissues, all hospitals throughout the world collect tissues from their patients in this exact same way. So we could be sent paraffin blocks from cancer patients in Puerto Rico and do these immunohistochemistry assays, these MSI analyses. We could receive paraffin blocks from Europe. We could see paraffin blocks from China and do these same assays. Whenever you have a clinical assay that requires frozen tissue or fresh tissue, like placed in growth culture media, assays never work. And that's how these used to be done when I was a resident. And that, I like to think that wasn't very long ago, but it probably evidently was. At least my kids say it was. So this whole ability to perform these on these routinely acquired clinical tissues is a really huge plus in our evaluation of these patients. I think it's what's really revolutionized our ability to detect these patients better. So what exactly is the formalin fixation and paraffin embedding process? So I think most people are familiar with what pathologists do. We look at H&E stain slides under the microscope to give a diagnosis. Cancer, no cancer, what type of cancer, is the cancer spread beyond the organ? But how do we get these slides? This is what we start with. We've already seen this ugly, horrible picture. How do we get these slides based from this? And that's what I want to discuss in the next few minutes. When we have our gross specimen here, a big uterine tumor, and we do the same for colon cancers as well, the pathologist will take careful sections of here of the endometrial tumor and the underlying myometrium, and these have to fit in these little tissue processing cassettes. And I put a nickel in here because that's the size of the tissue that will fit. It's about the width of a nickel, and it's about the thickness of a nickel. So this is kind of, you almost have to be an artist to do this because you have to picture in your mind, okay, microscopically, what do I want to see and how do I take sections of this with my scalpel to fit into a cassette in order that I get this. It's in some ways, it's almost like being an artist. So once you have your tissues in your tissue processing cassettes, these are fixed in formalin. And think of formalin as like a pickling agent. Basically what formalin's doing is cross-linking DNA, it cross-links proteins, it cross-links membrane lipids to fix the tissue and make it stable. If we were just to take tissue slices like this and leave them out in the air, the moisture in the air would degrade them and they would be gone basically within a couple of days to a week. When you fix them in formalin, it makes these tissues stiff and it keeps them preserved for almost forever basically. After this formalin fixation step, we dehydrate the tissues in a series of increasing concentrations of ethanol. What ethanol is doing is driving water out of the tissues. So whenever you put anything that has a little bit of moisture in it, in a high concentration of ethanol, the water is going to be drawn towards the ethanol. Water here is the enemy. You don't want any water in tissue because it'll help degrade it further. So the ethanol really helps to dry the tissues. So once you have your tissue that's been fixed and then dried in these ethanols, this takes a series of like 12 to 24 hours. The tissue is in kind of this little shriveled up mess. It gets embedded in this same cassette. This is paraffin. It's basically just melted wax that's then cooled. And this allows a little stage for the histotechnologist in the histology lab to cut very thin sections, and these are like 3 to 5 micrometers in thickness. Place these on the glass slides, and then these are stained with hematoxylin and eosin. So it's actually a pretty intricate process to get from here to here. And while this may look kind of easy to cut sections and put on a slide, try it one time. It's one of the most frustrating things you'll ever do. So the histotechnologists in the histology lab are truly gifted that they can do this. As I've mentioned, the paraffin block has really become the workhorse for clinical pathology analyses. We use this paraffin block to cut H&E stained slides. That's what we use for our cancer, no cancer, what type of cancer diagnoses. But in addition, we can cut unstained slides and perform immunohistochemistry. We can cut unstained slides, stain one with H&E. We can map tumor and normal. And you can use a scalpel or a needle and scrape away the tumor from the normal, collect this tissue, disaggregate it, and perform a PCR. And you could do MSI analyses, you can do mutational analyses, you could do MLH1 methylation analyses. So there's a myriad of different analyses you can do from this paraffin block. So if you have tissue in a paraffin block, it's a very, very valuable resource. This is just a cartoon schematic, kind of a simplification of how immunohistochemistry is performed. Immunohistochemistry is a method to detect protein. So we talked a little bit earlier this morning about how if you have a gene, a mutation that affects a protein, what we're looking for is presence of a normal protein. So here you have a cartoon, here's your glass slide, here's your tissue section of your endometrial cancer. Let's say like your antigen is one of these mismatch repair proteins, MSH2. You have MSH2, add a primary antibody to MSH2 that'll bind to it, a secondary antibody that helps develop the color reaction. So what's going to be really neat about this is that if this tissue contains MSH2 in the tumor cell nuclei, this will show up as a red or brown or reddish brown spot in the tissue section under the light microscope. And this is what this looks like here. This is a tumor, an endometrial cancer that has positive expression of MSH2 protein. So there is no mutation in MSH2 in this case. You can see all the tumor cell nuclei have very dark reddish brown staining indicating presence of MSH2. Now here's the case, here's another endometrial cancer that looks very different. This was stained for MLH1, and you'll note here the tumor cell nuclei are all blue. This is the normal color of an H&E stained slide. Now you do see some reddish brown cells in here, but these aren't the tumor cells. These are adjacent normal stromal cells. So the normal cells don't have that second hit. Remember, we're talking about 2 hits in these genes. You inherit one mutation, and then gradually over the decades, the second allele undergoes a mutation. In the tumor, both alleles from your mother and your father are lost, so you don't get protein expression. In the normal tissue, the normal protein is expressed, so you can always use that normal tissue as an internal positive control. And if any of y'all have done research in the research lab, it's always been stressed to you, have good controls for all of your experiments. So this normal tissue serves as a very good internal positive control that lets us know the immunohistochemistry is working. So this is a case of an endometrial tumor that has loss of MLH1. Now what's important here is that the immunohistochemistry doesn't tell us mechanism. So loss of MLH1 can be due to mutation, that's hereditary or Lynch syndrome, or it could be due to methylation of the gene, which is sporadic or non-hereditary. And we have the laboratory assays that can help sort that out. So these are the different circumstances or scenarios with immunohistochemistry or IHC. So if your primary defect is in MLH1, and that's if you have a mutation or MLH1 methylation, you'll lose MLH1 and you'll also lose PMS2 expression. Remember, these proteins tend to act in pairs. And so if your primary loss is MLH1, the PMS2 protein doesn't have its binding partner anymore and it'll get rapidly degraded. Similarly, if you have a mutation in MSH2, you'll lose MSH2 protein by immunohistochemistry and its binding partner MSH6. The MLH1 and PMS2 will be normally expressed. If your primary defect is in MSH6, a mutation in MSH6, the MSH2 protein still has intact protein expression, but you'll get loss of the MSH6 protein. And similarly, if you have mutation in PMS2, MLH1 is almost always still expressed, but you'll get loss of the PMS2 protein. What's nice is that nature almost always follows these rules, but not always, but nearly always. So the examples I've shown you by immunohistochemistry are relatively easy. I mean, this is positive, right? This is an endometrial tumor that has very good positive expression of MSH2. Here's an endometrial tumor that has loss of MLH1. You see the blue nuclei instead of reddish brown. We have good internal positive control. This is the stuff that the pathologists in training can easily recognize. You know, that's why they're smiling and happy, because this is easy. And so if life was always this easy, we would always be smiling and happy. Unfortunately, life isn't always that easy. So this is a very poorly differentiated signet ring cell carcinoma of the colon. In these cases, the tumor cells microscopically are very, very small. So the tumor itself, grossly or endoscopically, when you look at the ugly endoscopic pictures, you see this big, huge tumor. Microscopically, though, the tumor cells tend to be very, very small. They're so small that they're kind of the same size as the lymphocytes and endothelial cells that are within the tumor too. So when you look at this microscopically, you say, well, yeah, I see reddish brown cells, so MLH1 is expressed here. Actually, it's these cells in between the positive cells that are all the tumor cells. These are lymphocytes and endothelial cells lining blood vessels. Those are the internal positive control. These are the types of cases that are very, very difficult to recognize. This was a patient that had MSI high by PCR-based analysis and ended up having an MLH1 mutation. Here's another scenario where it can be very difficult to recognize the immunohistochemistry pattern. This is another colon cancer, very poorly differentiated. It has about 1 zillion tumor-infiltrating lymphocytes. So here's the poorly differentiated colon cancer. Here's all the lymphocytes infiltrating. This tumor infiltration of lymphocytes is a characteristic feature of these MSI-high cancers. We don't understand the mechanism of it, but it's thought that these MSI-high tumors have a different antigenicity that elicit a more intense immune response. So again, when we look at this microscopically, here's MLH1 immunohistochemistry. Well, yeah, there's lots of positive cells, so MLH1 is positive. But when you look more carefully, the positive cells are all those tumor-infiltrating lymphocytes, and the tumor cells themselves are completely negative. So again, this is a tumor with loss of MLH1. So the problem cases that give pathologists fits. Uncommonly, there's MLH1 mutations that result in expression of a non-functional protein. So by immunohistochemistry, we'll see positive MLH1 expression, but then when we do the MSI analysis, there'll be an MSI high tumor. So something doesn't fit. And when that happens, the first thing the genetic counselors will go after is they'll sequence the MLH1 gene, because that's a that happens where you have a truncating mutation that results in expression of a protein, but it's a non-functional protein. Other problems that we've run into sometimes is that internal positive control isn't positive, and it's very easy for pathologists to overlook that, and I'll show you some examples. So here's a poorly differentiated endometrial cancer. MLH1 was positive, MSH2 positive, PMS2 positive, and we initially interpreted this as, oh, MSH6 is negative, so the patient must have an MSH6 mutation. Well, if you start looking around, the stromal cells, here's a stromal cell, stromal cell, stromal cells. The stromal cells aren't positive either. The internal positive control here didn't work. If the internal positive control doesn't work, we don't trust the test and we'll repeat it until you do get the internal positive control working. In this case, we repeated it again, did some longer incubation times, internal positive control expressed and the tumor expressed as well. Here's another example of that. This was a colon cancer that had metastasized to the liver. Initially, this was read as MLH1 negative, and they're right. There is no MLH1 expression in this tumor. This patient had MSI analysis done. It was microsatellite stable. The patient was younger, so they thought, well, maybe this is Lynch syndrome, had genetic testing done, no mutation identified. We went back and looked at this, and I said, well, yeah, the tumor's negative, but the stromal cells are negative too. So we repeated on this block, and still the same result, that wasn't working. So this tumor happened to be pretty large, involving the liver. We basically just looked at a different section of the metastatic colon cancer, repeated the immunohistochemistry, and it was just floridly positive. So this patient had a sporadic colorectal cancer and not a hereditary colon cancer. Unfortunately, we wasted a lot of money with the genetic testing trying to prove that. So a second tool in our tool belt is microsatellite instability, or MSI analysis. Now, in contrast to immunohistochemistry, which is measuring protein, now we're measuring DNA. This is a PCR-based test. We're still using that same formalin-fixed, paraffin-embedded tumor. We assay a panel of 7 different microsatellites recommended by the National Cancer Institute, and these are listed here. And following DNA amplification, we analyze these chromatograms with an ABI genetic analyzer. And this is what a typical chromatogram will look like. This is for the microsatellite BAT25. And this is a case where the MLH1 immunohistochemistry was negative in the tumor. So microsatellite instability analysis, it also needs an internal positive control. So we use normal tissues in this. So in colon cancers, we typically have a proximal or a distal margin that doesn't have tumor. So we'll analyze that normal tissue. In an endometrial cancer, we may use like the ovary that doesn't have any tumor, or cervix that doesn't have any tumor. So when we analyze the normal, we get this characteristic profile of what the peaks look like for BAT25 on the chromatogram. In the tumor that has microsatellite instability, the tumor DNA will have these same peaks. There will always be some extra. That some extra can be variable, but there will always be the normal plus some extra peaks. So that's why we need this normal to compare this to. If all I have is this, I can't tell you if this is a tumor with high levels of microsatellite instability or not. I need this normal to compare to. So if we see our tumor DNA looks like our normal in all 7 cases, that's no allelic shift, that's called microsatellite stable. These tumors are almost always sporadic, they're not hereditary. If we see allelic shift in 3 or more of our 7 markers, that's termed MSI high, and that can be due to MLH1 methylation or mutation of one of the DNA mismatch repair proteins. The one that's kind of annoying is the MSI low, because we don't know what its significance is. So if you only have this kind of shifting pattern in 1 or 2 of the markers. This has been previously looked at in a large population of, from the Netherlands, where they had some very carefully characterized patients. So they had patients that had both colorectal and endometrial cancers. So these were all women, and they had all known MLH1 or MSH2 mutations. So this is a very busy figure, but if you just concentrate on what's in black, black boxes represent microsatellites that had microsatellite instability. This is colon cancers up here. This is endometrial cancers from the same patient. So this is 2 cancers from the same patient. In almost all cases, the colon cancers had more microsatellite instability than the endometrial cancers. And in fact, the endometrial cancers more often had microsatellite stability, so no allelic shift in any of the markers. Now, we don't know why this is so, why the colon cancers have higher levels of microsatellite instability than the endometrial cancers, but this does become clinically relevant and important, and I'll show you an example of an important case later in the talk. So I'm not going to spend much time on MSI low tumors because these are kind of an unexplored area right now. We really don't fully know what the clinical significance of these. In a previous retrospective study we had 55 colorectal cancer patients. All of these had MSI low tumors, so only 1 or 2 microsatellites shifted in the MSI analysis. 53 of these 55 had all 4 proteins positive by mismatch repair immunohistochemistry. So for these 53 patients, we assumed that they did not have a hereditary colorectal cancer syndrome, that they had a sporadic colon cancer. But 2 patients are interesting. One was a 53-year-old, MSI low rectal cancer, and had loss of MSH6 by immunohistochemistry. Pathologically, they had an MSH6 mutation detected. Now, why in this case did MSH6 result in MSI low instead of MSI high? We don't know. This is one of those weird cases that give physicians fits. Second patient was a 68-year-old, again a rectal cancer, MSI low, had IHC loss of MSH2 and MSH6. This patient didn't want to undergo any genetic testing, but most likely has an MSH2 mutation. So I think some lessons you can learn here are, 1, these MSI low tumors in the colorectal patients tend to be rectal cancers. It's our limited experience here. Also note their ages. They tend to be older than 50, older than 50. So MSI analysis, just like immunohistochemistry, can have its problems as well. 1, that this is a PCR-based test, so you have to have sufficient tissue in order to do the polymerase chain reaction. This can be a big problem in mucinous tumors of the colon. You don't see mucinous tumors of the endometrium so much, but some colorectal cancers that are MSI high have a lot of mucin production. So again, grossly the tumor looks really big, but microscopically it's almost all composed of acellular mucin with just a few tumor cells. So it's very hard for us to do PCR-based analyses on those tumors. You can have a case of too many tumor-infiltrating lymphocytes that would skew results. So I showed you that example that had a zillion lymphocytes coming into it. All of those have normal DNA. So if you have too much normal tissue contaminating your tumor, if your tumor has high levels of microsatellite instability, you may not be able to see it because of this contaminant of normal tissue. Also, it's hard to perform the MSI analysis on biopsy material. Typically, biopsies, all we have is cancer. We don't get the normal tissue that goes with it. So to go through the scenarios, combining immunohistochemistry and mismatch microsatellite instability. If you have all 4 proteins expressed by immunohistochemistry and it's microsatellite stable, then Lynch syndrome is very unlikely. This patient most likely has a sporadic endometrial or colorectal cancer. If you have by immunohistochemistry loss of MSH2 or PMS2 or MSH6 and it's MSI high, that's very suspicious for Lynch syndrome, and the genetic counselors proceed to direct to genetic testing. Here what's nice is that the immunohistochemistry helps to point you in which mismatch repair protein is abnormal. If you don't do immunohistochemistry and all you have is MSI high, You have to do testing of MLH1 and MSH2 and MSH6 and PMS2. It's very laborious and very expensive. In this case, if the tumor has loss of MSH2, you know to do your genetic sequencing on just the MSH2 gene. So in the last scenario, if your tumor has immunohistochemical loss of MLH1 and it's MSI high, this is that uncertain one because MLH1 can be sporadic due to MLH1 methylation and could be a mutation. And the immunohistochemistry doesn't help you sort that out. So this is where you could do the MLH1 methylation test and the BRAF mutation analysis to help you out. So the MLH1 methylation assay, again, we use tumor from our paraffin block. We treat DNA with bisulfite. It converts the cytosines to uracils, but the methylated cytosines are resistant to this conversion, and that's the basis of this assay. And again, it's basically a PCR-based test. So with this, we always do control. So K562 is a leukemia cell line that's known to not have methylation of MLH1, and this is what its chromatogram looks like. RKO is a colon cancer cell line that's known to have loss of MLH1 due to MLH1 methylation, and this is what its curve looks like. And then we have our tumor. In this case, it had IHC loss of MLH1. It has presence of this methylation peak, so we would say that this is an MLH1 methylated tumor, most likely sporadic. So just to complete our scenarios, IHC loss of MLH1, it's MSI high, no MLH1 methylation detected. We think this is likely Lynch syndrome, and the genetic counselors proceed with sequencing of the MLH1 gene. If you have loss of MLH1, it's MSI high, but MLH1 methylation is detected. It's almost always a sporadic tumor, and we don't proceed with any further testing. I think you can start seeing that the importance of this MLH1 methylation assay in the clinical laboratory. So in a retrospective study of endometrial cancers, we examined like over 300 endometrial cancers. We found that about a little over 50 had immunohistochemical loss of MLH1. We applied Society of Gynecologic Oncology criteria, which are basically similar to revised Bethesda criteria or Amsterdam 2 criteria that take into account young age of patient and family history of colon or endometrial cancers. And we found that 22 of these patients do meet these SGO criteria. However, 12 of these 22 had MLH1 methylated tumors. So if you were to not do the MLH1 methylation assay, 22 patients would go on to have very expensive genetic sequencing of their mismatch repair genes. If you do the MLH1 methylation assay, you save 10 patients that expense. So beyond evaluation for hereditary cancer, is there any clinical significance of this MLH1 methylation? In colorectal cancer, it's definitely been shown to be associated with improved survival stage for stage, and also resistance to 5-FU-based chemotherapy. So it's now thought, and this is still a little controversial, but for early stage colorectal cancer patients that have MLH1 methylation in their tumor, if they don't have any lymph node metastasis, they probably do not benefit from 5-FU based chemotherapy. For endometrial cancer, the clinical significance of MLH1 methylation is very uncertain. There's basically 3 different published studies. Each have shown 3 different things. One study has shown a survival benefit of MLH1 methylation. One has shown worse prognosis, and a third one has shown no difference. So what this means for endometrial cancer is still very controversial. So is it necessary to perform both immunohistochemistry and MSI analysis? I prefer to do both, even though they kind of tell you the same thing sometimes. It's nice to have two independent assays for some of these more difficult cases. And I'll show you an example here. This is a colorectal cancer that was found to be MSI high. This is the MLH1 protein expression. It expresses MLH1. This is the MSH2 expression, and it has expression of MSH2. This is MSH6. The normal mucosa has very good expression of MSH6, but the tumor either has loss of MSH6 or in some instances very faint expression of MSH6. So without the MSI results, it's very hard to interpret this. Since this was an MSI high tumor, this patient had sequencing for MSH6 and was found to have an MSH6 mutation. So BRAF mutation is another PCR-based assay that can be used in sorting out whether a tumor is MLH1 methylated or MLH1 mutation. Very, very simple assay. It's a mutation hotspot. Requires very little DNA. Many different labs can do this. It's most useful in colon cancers. If there's presence of a BRAF mutation, it means that Lynch syndrome is not likely. And no one knows the reason for this, but for whatever reason, Lynch syndrome colon cancers do not have BRAF mutations. Unfortunately, BRAF is not useful for endometrial cancer because sporadic endometrial cancers have very, very low frequency of BRAF mutation. There are some special clinical problems with Lynch syndrome-associated endometrial cancer that I want to go over in the next few slides. Endometrial cancer is associated with a precursor lesion called complex atypical hyperplasia. And we get asked all the time, can this be used for testing? And the answer is, in theory, yes, and the literature supports this. Unfortunately, the cases I've seen have very weird results. Sometimes a hyperplasia can have positive expression of protein, and then 1 millimeter away, negative expression of protein. And this is in a patient that I know has Lynch syndrome because we know the mutation results. So because the results are so iffy, I prefer not to use hyperplasias. And similarly, colon cancers have precursor lesions, adenomas. I don't think adenomas are very good to use either. There's a very special clinical scenario of young women with sporadic endometrial cancer. So you've heard pretty much all day that this young age is very, very important. Unfortunately, there's a lot of young women who get sporadic endometrial cancer not due to a mutation of one of these genes. It's a very common clinical scenario. These patients tend to have a higher body mass index, so they tend to be obese. They may have type 2 diabetes, and they may have fertility problems. Also in these patients, synchronous primary ovarian cancers are extremely common. So you have these sporadic patients that have 2 different tumors and they're young. So clinically, it can look a lot like Lynch syndrome. But when you do the mutational analyses or the tissue testing, they don't have test results that look like Lynch syndrome. This is a publication from 2005 that looked at this specific issue of women that have synchronous, means they have them at the same time, ovarian cancer and endometrial cancer. So you've heard from previous talks that when you have 2 or more cancers, that's a big warning sign or a red flag for Lynch syndrome. So we had a set of almost 60 patients who fit this bill who had synchronous ovarian and endometrial cancer. Only 12 of these patients had MSI high tumors, and only half of these, or 6, had tissue testing findings suggestive of Lynch syndrome. So it would have cost a lot of money to do sequencing of all 59 patients. By doing the tissue testing first, we narrow it down to only 6 of 59 really need this sequencing, more expensive sequencing tests. MSH6 mutations are also another problem area. Women with these MSH6 mutations tend to develop endometrial cancer preferentially to colon cancer. Not all the time, but you'll see many MSH6 families have lots of women with endometrial cancer, but no colon cancers, or maybe one male relative with colon cancer, but he's in his 60s or 70s. So it doesn't look like the prototypical Lynch syndrome family. Also, these women tend to be older. They're not younger than 50. Many of them are older than age 50 when they develop endometrial cancer. So women with MSH6 mutations, these are the types of families that you tend to not pick up if your screening procedures are solely based on young age or family history of colon cancer. PMS2 mutations. For endometrial cancer, there's very little experience, no publications on this. For colon cancer, there's only a couple of publications. We haven't published these findings yet, but in our retrospective analyses of endometrial cancer patients, we found 5 that had MSI high tumors that had PMS2 loss by immunohistochemistry. And again, it's very informative to look at the ages of these patients. One very old, 87, 75, 66, 51. Only one of these was younger than 50, but even this patient had no family history of colon or endometrial cancer. So it looks like these PMS2 cases are going to be very similar to MSH6, older patients, and not as much colon cancer or endometrial cancer in these families. This is a topic that was briefly discussed in the previous lecture. Can we recognize these MSI high cancers under the microscope? Could this be a way that we can screen for these? You'll hear that a subset of MSI high colon cancers are these right-sided colon tumors. So they arise in the cecum. They may have a lot of mucin production, a lot of tumor-infiltrating lymphocytes. They have this kind of medullary histology. They may have 2 or 3 different histologies. Unfortunately, these microscopic features really are not reliable in picking up Lynch syndrome cases. Really, about less than 50% of Lynch syndrome colon cancers have these microscopic features. So this is what a typical colon cancer looks like under the microscope. This is a sporadic colon cancer, not due to Lynch syndrome. This would be one of those mucinous colon cancers due to like an MSH2 mutation. Here's all the acellular mucin here, and here's just a few tumor cells here. So both of these photomicrographs are taken at the same magnification. Look at all the tumor cells here that you can use for PCR analysis versus how few tumor cells there are here for the same PCR analysis. That's why the MSI analyses sometimes don't work very well on mucinous tumors. We've seen this picture before. This is this kind of medullary histology where the tumor is very poorly differentiated and it has a lot of tumor-infiltrating lymphocytes. So similarly, this question's been asked of endometrial cancers. Are they pathologically distinct? Can we recognize these under the microscope? Not really, but that's my opinion. I think there's other authorities that look at this a little bit differently, and if you want to read some more about this, Rob Soslow at Sloan Kettering thinks that you can recognize these under the microscope. Some of the characteristics that have been looked at for these cancers are the tumor-infiltrating lymphocytes, undifferentiated histology, mixed endometrioid and non-endometrioid histology, and lower uterine segment anatomical location. And we'll look at examples of these. This is a undifferentiated endometrial carcinoma compared to a grade 3 endometrioid carcinoma. All of the examples of these that we've seen at MD Anderson are due to MLH1 loss by immunohistochemistry, but it's not due to mutation, it's due to MLH1 methylation. So none of these have been Lynch syndrome associated. These tumors tend to have smaller tumor cells compared to the grade 3 endometrioid. They don't express keratin proteins, and they have very poor expression of hormone receptors. This is an example of we recently had a 46-year-old woman die of an undiagnosed metastatic endometrial cancer. And when we first looked at the histology slides, I said, this is an undifferentiated endometrial carcinoma. And the fellow I was working with didn't believe me. I said, we'll do the MLH1 and MSH2 immunohistochemistries. MSH2 is expressed, MLH1 is lost. The stromal cells express MLH1. The tumor had high levels of microsatellite instability, and it had presence of MLH1 methylation. Here's an endometrial carcinoma that was, again, MSI high due to MLH1 methylation, and it looks very similar to that colon cancer, very poorly differentiated, and has lots of tumor-infiltrating lymphocytes. Anatomic location can sometimes be used as well. We've seen this picture before. This was the sporadic endometrial cancer. This is what most endometrial cancers look like. However, there's a whole class of endometrial cancers. They're not common, but we do see them, that the tumor, instead of arising in this part of the endometrial cavity, it arises in this part called the lower uterine segment. So basically, this is the junction of the endocervix. Here's endocervix, and here's endometrial cavity. And you can notice a very small little fluffy area of the endometrium here. This is the endometrial cancer. So here's the tumor here, and on this side, here's the tumor over here. And if you're not looking carefully, you can miss this. So here's the endometrial cancer. This would probably fit, if you remember the size of those tissue cassettes, fits in about 2 cassettes. So it's a very, very small tumor. Unfortunately, this was a serous carcinoma that had already spread to lymph nodes by the time of surgery. And this patient didn't do well, had a very poor prognosis. And this is a picture of her tumor that had spread to lymph nodes at the time of surgery. When we first started studying these lower uterine segment tumors, they're very, very uncommon. Out of like 3,000 hysterectomies, we found only 35 of these. But the characteristic that really stood out to us was look at the young age of these patients compared to the control group that had tumors outside of the lower uterine segment. So these patients are older than 50, yes, but they're significantly younger than our typical endometrial cancer patient. So when we saw this, the first thing we thought of, are these associated with Lynch syndrome? So we tested all 35 of these patients. We found that 12 of these had MSI high tumors, and 10 of these 12 are confirmed or likely Lynch syndrome based on mutational analysis or the tissue testing results. And this 10 out of 35 or almost 30%, that's a huge percentage. So if you think about the percentage of Lynch syndrome in the general endometrial or colorectal cancer patient population, we think it's like 2 to 5%, something like that. If we think about just young women with endometrial cancer younger than 50, the incidence is about 10%. So this finding of tumor in the lower uterine segment is really, really important. It's a good red flag for Lynch syndrome. Unfortunately, lower uterine segment location is really, really uncommon. So you don't see it often, but when you see it, there's a very good chance the patient has Lynch syndrome. So, it gets back to this question, are MSI high endometrial cancers pathologically distinct? So, really, in my experience and in looking at the literature, the pathologic features that are associated with MSI high are increased tumor infiltrating lymphocytes, but only for younger patients. If it's in an older patient, it's not associated with Lynch syndrome. This undifferentiated histology, but again, I've never seen this in Lynch syndrome. I've only seen it in MLH1 methylated cases. And this lower uterine segment location, very good for Lynch syndrome, but just not very common. Only about 3.5% of all endometrial cancers arise in this lower uterine segment. So here's the interesting case that I was alluding to earlier. Yes. I'm almost done. Yeah, it won't get any better, I don't think. I'm sorry. I'm a pathologist, and so I think all these laboratory tests are great. They're always going to help you. They're always going to point you in the right direction. Here's an interesting example where the laboratory test really didn't help us very much. 51-year-old woman who had an endometrioid type endometrial adenocarcinoma, and this one was centered in the lower uterine segment. However, and so we were very excited about this. Pathologists and doctors, we get excited by weird stuff, right? I mean, patient has cancer, that's a terrible thing, but we get excited by it. By immunohistochemistry, all 4 proteins were expressed. And so we kind of thought, well, that's kind of weird, but maybe this is one of those MLH1 cases where the protein's expressed, but it's an abnormal, non-functioning protein. So we said, let's do MSI analysis on this. So we did MSI analysis, and it was MSI low. And so now we started thinking, well, this is really crazy. Our tissue testing results aren't really pointing to Lynch syndrome, yet we have a tumor that's centered in the lower uterine segment. So the genetic counselors didn't believe this either, and so they said, well, let's just test this patient anyway. And it was found that she had a pathologic MSH6 mutation, and this was a mutation that resulted in a non-functional protein being expressed. So the immunohistochemistry was picking up MSH6, but it wasn't functional. So I think the big lesson learned here is, we have a lot of great laboratory tools that can help us here, but sometimes you have to go with your instinct too, and not just focus on the laboratory assays. So, we have laboratory assays that are telling us this is not Lynch syndrome, but we have a clinical feature, this a tumor centered in the lower uterine segment that is pointing towards Lynch syndrome. So fortunately, we had some amongst us that were smart enough to keep pursuing this, and they found this MSH6 mutation. So this all kind of leads to the question, we have these great tools in the clinical pathology lab, which patients should we apply them to? And this is really the million-dollar question. No one has a good answer to this. And many places do things very differently from each other. At Ohio State University, they do this tissue testing on all their colon cancer and endometrial cancer patients. They don't screen by age or by family history. At MD Anderson and at Mayo Clinic, they screen all colon cancer patients. And more recently, we've started screening all endometrial cancer patients. If your clinical practice sees a lot of early stage colon cancers, remember we discussed that this sporadic MSI high has a better prognosis it makes a great deal of sense to screen your early stage colon cancers for MLH1 methylation. So in my last couple of slides, I just wanted to go through some more recent work that we've been doing with the endometrial cancers. These are the criteria that we've previously used to screen patients with endometrial cancer to see if they have Lynch syndrome or not. And many of these criteria are very similar to the Bethesda criteria or Amsterdam criteria. We're using age as a criterion, and we're using and we're using family members with colon cancer or endometrial cancer, and we're doing this 2 or more tumors. So very similar criteria, just have a different name. So we asked a very simple question. If we were to apply these SGO criteria to a set of very carefully characterized endometrial cancers for MLH1 methylation and immunohistochemistry, can they do the SGO criteria match up with the tissue testing results? So we have a little over 400 endometrial cancers, did immunohistochemistry for the 4 mismatch repair proteins. As expected, most of these tumors are sporadic. Over 350 have intact nuclear expression of all 4, so they're sporadic. Loss of nuclear expression for MSH2 or MSH6 or PMS2, we call these likely Lynch syndrome cases. Loss of MLH1, we did MLH1 methylation analysis. If the promoter was methylated, we said it was sporadic. Unmethylated, we said was Lynch syndrome. So out of all these analyses, we found that there were 43, or almost 11%, that we thought were likely Lynch syndrome. So what gets interesting is when you start apportioning these 43 N of 43 to whether they meet SGO criteria, yes, or do not meet SGO criteria. So look at the what's interesting is that only 14 of the 43 met the SGO criteria. This potentially means that if you're only using SGO criteria, you're going to miss Lynch syndrome in 29 of our patients, a good chunk of the patients. But also look at the characteristics of these tumors, which I think is interesting. In the 14 patients who meet SGO criteria, so these will be younger patients, these will be patients that have positive family histories, almost all of the defects are due to MLH1 or MSH2. That occupies the biggest chunk of the pie, with only very rare cases of MSH6 loss or PMS2 loss. On the other hand, when you look at the N of 29 that do not meet SGO criteria, so these patients are older and they may not have much family history of colon cancer, the proportion of the pie really gets skewed. So yes, MLH1 and MSH2 are still more common, but look how many more MSH6s now you have here compared to here. Look how many more PMS2s you have here compared to here. So these SGO criteria are missing patients, but they're really missing quite a few of the MSH6 and the PMS2 patients. And that may be why you hear us say all the time, and you'll always hear in the textbooks, that MLH1 and MSH2 are the most common defects in this syndrome. That may be because we've always tested young patients with positive family histories. When you do this testing more applied over to a patient population, you start uncovering these PMS2s and MSH6s. And this is pointing out, this is just a different way of expressing this data. Again, the younger patients with family history here, their median age at diagnosis was less than 50. Median age at diagnosis over here, 63. This looks exactly like sporadic endometrial cancer. This is the exact age for all of our sporadic endometrial cancer patients at MD Anderson. I think an important concept to get across here, though, is when you set out to do this testing in the clinic, really sort out for yourself what your goals are. So if my boss was to come to me and say, Russell, I want to start testing for Lynch syndrome, the first thing I would ask is, do you want to capture all the patients, or do you want to have a lot of positives to show for the patients that you test? because if you want to capture everybody, then you don't want to screen by younger than 50 or positive family history. You're going to miss a lot of patients. But if you want to see a lot of positive results, a lot of bang for your buck, then you want to test the patients that are younger than 50 that have the positive family history, because then you'll have much greater sensitivity. So you see how specificity, if your age cutoff is younger than 50, your specificity is 77%. So a lot of your tests are coming back as probable Lynch syndrome. The specificity really goes down as your age of your patient starts climbing. So you really have, when you start doing this, you really have to sort out for yourself what's important. Do you want to capture a lot of positives for each test you test, you want it to be positive, or do you want to make sure no patients fall through the cracks? Very different clinical questions. Just my last slide I wanted to show. This nearly 11% Lynch syndrome. This is a different number than what you've been hearing all day. You've heard like 2 to 3%, 5%, something like this. So is this reality, or is this just kind of a weird study that we cooked up and we're not going to be able to replicate the results? So there's 2 other studies in the literature that we can compare to, and I think our findings are very, very comparable. Ohio State did a similar study, a smaller number of endometrial cancer patients. They also did immunohistochemistry. What's a little bit hard for their results is that they did not do MLH1 methylation. So we kind of figured our rate of MLH1 methylation, and we imputed that into their test results, and we found that almost 8% of their tumors would be likely Lynch syndrome. So 8%, very comparable to 10.5%. This large study recently published in the Netherlands also looked at almost 180 patients. They did immunohistochemistry and they did MLH1 methylation. And they found that about 6% with a confidence interval of 3 to 11% had probable Lynch syndrome. So see, our 10.5% falls right within this confidence interval range. So to me, it's looking like somewhere between 6 to 10% of all endometrial cancers will be most likely Lynch syndrome. So one thing I kind of want to leave you with, and this is what sort of makes this field a little uncertain, is could there be possibly 2 different types of Lynch syndrome? So one is the traditional type that we've been talking about all day. Patients younger than 50 have lots of family history of colon cancer in their families. These are the ones that are traditionally recognized by the clinical geneticists. But then maybe there's an atypical type. These are the ones, the MSH6 mutations, the PMS2 mutations, where there's not many colon cancers in the family. The colon and endometrial cancers that do develop, the patients tend to be older. So maybe there's some modifier genes in these families that kind of squelch a little bit this effect of the defect in DNA mismatch repair. I just want to touch on very briefly ovarian cancer and Lynch syndrome. The reason I'm being brief with this is there's really not much data on ovarian cancer and Lynch syndrome. By far, the most common cancers in Lynch syndrome are colon and endometrial. Ovarian's also there. Its lifetime risk is thought to be only, and I put only in parentheses, 10%. That's still very large compared to the general patient population. The Stanford group has probably done the best study of ovarian cancer in Lynch syndrome, but even their study's not very big. Most of their tumors tend to be clear cell carcinomas and endometrioid carcinomas. And that's very interesting because you heard Dr. Liu this morning mention that for BRCA, the typical ovarian cancer histology is high-grade serous carcinoma. So here you have 2 different DNA repair genes. BRCA, a defect in it, leads to serous carcinomas of the ovary, versus the DNA repair genes and the mismatch repair pathway, they lead mainly to clear cell carcinomas and endometrioid carcinomas. It's kind of an interesting comparison. No one's ever done MSI analysis of these tumors, so we don't know if they're MSI low or MSI high. This is opportunity for someone to really do some good work in the ovarian cancer field. And at the end of your handout, I have some references in the literature. If you have a hard time getting any of these and you're interested in more reading, just email me. I'd be happy to send you the PDFs and you can read them pretty easily. Thank you very much, and I apologize for my voice.